thank everyone for joining in. I will be letting people come in as they see fit. I'm Leticia Vaca, and I want to welcome you all to our talk tonight on the double-edged sword of research for BIPOC. Now, this is just a really lengthy name to talk about the dilemmas around BIPOC folks wanting to participate in research and some of the issues that come up in being able to provide adequate diagnoses, treatment, and overall coordination of care. So I started Urban Health Group to really fill in the gaps in what I see with the healthcare system. So we are currently a virtual boutique concierge for healthcare navigation and also mental health support. So we have a few different branches of how we provide care and fill in gaps. One of that being healthcare navigation on crisis supports, connecting people directly to mental health support, consulting and training for companies who want to provide wellness programming, and also my Plan Well for Care course, helping develop a community of informed and empowered BIPOC folks, really making sure they have a plan in place in case of a medical emergency. So with Urban Health Group, our main goal is to empower Black, Indigenous people with tools and support to navigate their needs for better wellness. Ultimately, our goal is to eliminate healthcare disparities and reduce healthcare biases for this group of folks. So we're addressing this head on through strategic partnerships. So tonight we've welcomed MD Action to talk about what they're doing as far as research, but also how mindful they are in reaching out and making sure research is inclusive. So I will introduce the presenter in a little bit, but I want to share a little bit about me. So sorry, I'll be letting folks in. Why do I care so much? Overall, I've been working with folks since I was 17 in different facets. So in human services and health, but ultimately my own personal loss is what led me to be in the field of healthcare. Multiple family members passed for preventable, complex, chronic diseases. And I saw how my family really struggled with feeling like we had adequate support. So I essentially got in the industry to be the change I wanted to see. Never even heard of medical social workers, and don't believe that my family had the opportunity of getting advocacy and support. So I lead with my humanness and my own personal experience. Aside from having degrees in education, I want to lead with my humanity and my own personal experience that informs my work. I have a specialty in medical psychotherapy and trauma, but ultimately, I really just enjoy working with folks with day-to-day difficulties. I believe in people, I believe in community. So anytime I have an opportunity to talk about some difficult things, which are health and mental health, I like to be able to provide supports in any way that I can. So my goal for today and our collective goal with MD Action is to provide a really brief, high-level history around the abuse and current mistreatment of BIPOC folks in the healthcare industry. We want to be able to talk about the benefits of inclusion of BIPOC in studies and research. We will learn a little bit about MD Action's current study on the chronic illness survey adventure. And at the end of the day, we want you to be able to walk away with some tips on how you can do your own research for health and other chronic conditions. Now, this is a really huge topic with COVID-19 and a lot of people really being confused, sometimes persuaded to either take the vaccine or not. And there's a lot of divisiveness around it. So we want to make sure that you have some really good, useful tips on how you can decide what would be a really good avenue when making informed choices for care. What we're not going to do is leave you hanging, make you feel bad, but you may notice your feelings more a little bit after this presentation. On one hand, we are talking about some really complex, difficult topics around race and supports in the healthcare industry, but we won't leave you hanging. So we'll make sure you have some resources and information that you'll have access to. And this is meant to be interactive. So if throughout our time together, you have questions, please enter that in the chat. If you want to share something, we are in community, so please feel free to participate in the chat. I will be monitoring it, and moderating the Q&A at the end. So some of the things we're hoping that you walk away from is really learning about some of the barriers to appropriate diagnostics of ME/CFS. And Jamie will talk to you a little bit more about what that is. You'll be able to learn some symptoms that look like everyday complications that folks are dealing with in more depth. And again, you'll learn some tips on how to do your own research for your health and other chronic diseases in this era of like all this information. How do you really sift through it and see what's going to be not only reliable, but accurate? So I want to know who's here. I introduced a little bit about myself and where I'm from. And in other circumstances, we will be able to see each other's face and hear each other's voices. So you don't have to unmute your mic if you don't want to, but please drop in the chat your name, where you're from, or where you're located at in the world right now. And if you ever participated in research, in a research study, why or why not? So I'm Leticia Vaca. I'm located here in Oakland, California. And I did participate in research when I was in college. And I did it because there was money attached to it. So as a struggling college student, I did it for that $10. Anyone else? And if you want to unmute your mic, you can raise your hand and I can open your mic. So if you don't want to open your mic, please feel free to put it in the chat so we can at least know where you're calling or where you're tuning in from. Okay, do you want me to unmute you? Okay.
Hey everyone, I do recognize some of the names of the people in the call, and if you are too crashed or wiped out because it's late for you, that's okay too. Oh, there's Wilhelmina. Hi Wilhelmina, thank you for coming.
Thanks for joining. And it's a lot later where you're at in Atlanta.
That's right. Goodness, I see a lot of familiar names and faces. Thanks for coming, guys.
I'm trying to see how I can unmute your mics because maybe it's just easier to say it. Okay, you should be able to unmute yourself.
Hello, everyone. I'm Michaela. I'm from Oakland, and yes, I have participated in research, mostly in school, and then I did a study a while back in Kaiser for autism.
Okay, thank you for joining. Okay, thanks for joining. Thanks for joining.
Everyone, can you hear me?
Yes.
It's Angel Brutus. Sorry that my camera is off and I'm driving, so I'm doing this safely. But I reside in Temecula, California, and work out of Chula Vista, just outside of San Diego. And yes, I too have participated in research. Actually, still participating in research now because I function in a role where it's not many women of color who do what I do in our field, in our industry. So constantly being poked and prodded about my lived experiences in my work that I do.
Got it. Thank you. And feel free to keep adding in the chat. Folks are coming in from a lot of different places. So I appreciate your time. I know you may be zoomed out, tapped out. I get that way as well sometimes, but there's some topics sometimes that really touch a nerve or touch my heart in ways that I want to be present for. So I'm aware of the huge ask of asking folks to come in and share your thoughts or maybe learn a few things in these after hours. So I thank you all for joining in. So how did this talk even come about? I know in my profession as a medical social worker and therapist, we talk about it amongst ourselves, but rarely do we talk about it amongst across disciplines. In the times that we have talked about these issues, it's been with other medical providers, and sometimes it's a clash. So this talk is really unique in a sense where we have a medical social worker and a researcher talking about our respective perspectives on the issue, but really wanting to come together to see how we can address this dilemma and actually provide a solution. So I can share a little bit about how this talk came about. And Jamie, feel free to jump in as well. But there was a study going on with Jamie, and she's really wanting to look for ways to connect to the BIPOC community to participate in it. So she reached out to me, we had a talk, and it really developed in more than just let's reshare information, let's reshare our content to say, how can we develop an ongoing good working relationship to better understand the issue, but also come up with a solution. And so over the past few months, we've been meeting almost weekly, trying to put our heads together and really develop something beautiful that we think that is useful. So I know from my own frustration is like, I'm tired of hearing about all the issues. Where are the solutions at? Where are the efforts at? The initiatives to bring about positive change. And this is Urban Health Group's effort and also ME Action's effort to see how we can collaborate to really address this gap. Anything else you want to add about that? Okay.
I think you nailed it.
All right. So some of the reasons why the dilemma around the difficulty of getting BIPOC to participate in research or have an overall mistrust in the medical system, whether that be the doctors are like, I'm not going to do any research. And I talked to Jamie about this, like, I don't know that I would just jump on some research without really understanding a few details about it. But there's 3 historical events that really stick out, especially when it comes to African Americans, around where did this mistrust and neglect come from? So some of the earliest research looks at the foundation of surgery. There was a doctor in the early 1800s who was performing surgical procedures on an enslaved woman. So not only is that like terrible, but when we think about how the evolution of ethics and getting informed consent started about, this is one of the earliest instances that we can point out. The other thing that comes out is the study of syphilis for African-American men, which was one of the longest studies from the CDC, Tuskegee study, where treatment for syphilis was not administered even when there was treatment options. So when we look at this, how this issue over a long period of time with the implications of not receiving adequate care when care was possible can really, it resulted in death. It resulted in families being broken apart and ultimately like quality of life. There's a study as early as 2016 where medical students perceive pain differently for Black patients versus white patients, that Black pain was thought to be not as significant or as intense. So when we think about the implications of pain being poorly managed for African Americans, this is an issue that comes up even to this day that I'll talk about in a bit. But there's some long-term historical events that have happened that, we hear within our families. I know I can speak for myself, like, don't trust them, be sure, so there's a lot of caution and concerns around using the healthcare system as a reliable source of support. The other thing I wanted to add in there is the identity intersectionality around, well, what does this mean for LGBTQ community who are also BIPOC, right? We know that there's still an issue around medical providers being adequately trained and sometimes being insensitive around the needs of this community. There's also research that shows that socioeconomic status doesn't really change that much for BIPOC communities. So it changes in general between like folks who live in poverty versus folks who are well off. But when they did research on folks who had stable financial resources, the health outcomes for BIPOC were still poorer than compared to the white population that they studied. In the research that I'm referencing, they looked at medical doctors, Black medical doctors versus white medical doctors, and there was a higher prevalence of cardiovascular diseases for the Black doctors compared to the white. So it's an illusion to say that because you're more well off that you will have better care or better health outcomes. And so that's just something to consider. When we think about barriers, what are the barriers that exist? Now, there's a few ways of looking at barriers. In the research that I looked at in particular, it was the barriers to use. So we could also look at access, like, you know, are there enough providers in a respective location? But in this research in particular, it looked at 54 different article reviews amongst different ethnic backgrounds in different countries. And they were able to identify 3 different levels in which barriers can present themselves. So on the patient level, it's those social determinants around age or perceived age, sex, your zip code. The other issues that come up is the language barrier, that between physician and patient, that there's language differences. Also finances, not only on like having access to insurance, but like the ability to pay for medication and other needs. Immigration status becomes another issue on patient level, where folks who, depending on their status, may not approach care for concern of being deported. There's also some cultural perceptions about their symptoms. So sometimes folks may have chest pains, but they will discuss their symptoms in other ways that may be unclear for the medical provider to understand. And again, this element of mistrust. So there's like a lot more, but this is just a brief snap of how barriers can present themselves on the individual patient level. Now, it also happens on the provider level, where folks come with their stuff, right? Their own biases, their own understanding of the world and their lens that can show up as discrimination in the healthcare setting. The denial of certain medications, like I've heard doctors saying, well, they're drug seeking, or poor adherence to care, or non-compliant. That's the word I'm thinking of. So certain group types who maybe there's poor pain management, but they're perceived as drug seeking. Neglecting the family involvement in care. So I know there's a certain ethic amongst medical providers that making sure the patient understands, but there's some cultural aspects of including family members in that process. Lack of cultural knowledge. That could be language, it could be family involvement, but sometimes it's values. So if a person may feel uncomfortable with receiving care from a male provider, you know, not really taking the time to make sure the patient has all the supports in the way that they best receive care. The authoritative communication style. So this, you know, we talk about the pecking order and the hierarchy that exists in healthcare, where I'm going to tell you what to do. It doesn't really allow for an adult conversation that respects rights to self-determination, that, you know, I may have a different way of caring for myself, but that authoritative communication style can pose as a barrier. Ultimately, sometimes providers come off as rude or dismissive, and I'll talk about how that is kind of woven into the medical paradigm. intrusive medical procedures. So I'll talk a little bit more about that in a bit, but not significantly, around just how you approach the body and bedside manners, and sometimes feeling like the medical process is really intrusive to the individual self. Now, the barriers that can exist on a system level, they vary far and wide. But when we talk about the rigidness of the medical paradigm, it's, well, you didn't meet this criteria, so no, you don't get access to oxygen, or you didn't meet this criteria, so no, you won't have access to durable medical equipment. So the rigidness of the system sometimes allows for these like huge, a crisis has to happen in order to get adequate supports. Also, the consumeristic approach, where patients are looked at as consumers. You paid your bill, you know, it's time for you to discharge from the hospital and you need to pay your bill. So sometimes that transactional exchange can feel like a huge barrier to making sure that I feel comfortable that the provider really knows my condition, is really invested in my care treatment plan. The system levels we know we're seeing right now with COVID-19 is wait time, where patients are backed up in the ER, difficulty moving amongst the system, and sometimes people leave the hospital even when they're feeling unwell. So the barriers, I'm not going to go there. They're not going to treat me until like 15 hours later. The referral system for people who have rare conditions or need specialized care, that sometimes working through these silos, the referral process is not as quick or smooth as needed. The lack of translation and printed material, where a lot of times, especially in the US and the Bay Area, I can speak about the systems that I work in. Yes, there may be a translator, but your discharge papers are still coming in English. There may be a few languages that it's translated in. So is it really a chance to learn your symptoms and treatment and follow-up care? That's really an issue in coordinating care. So all this stuff is just not historical. It's not just back in the days, back during slavery, back during, you know, Tuskegee time. These issues still come up today. And I can speak from my own family's experience of having some poor experiences in seeking care. Individuals, you may all have your own experience of feeling neglected or mistreated, or downright like sometimes under medicated or over medicated. So these issues still come up. So they're not so far off, and it's important enough for us to talk about it, especially in the areas of like pain management. So the story that we know we're all pretty familiar with is the story of Dr. Susan Moore. And this is earlier on during the pandemic, when we really began to learn the disparities of BIPOC folks contracting the disease, being hospitalized, and higher rates of mortality from COVID. So this doctor in particular talked about her poor treatment in the hospital, and she was also a physician, where she was complaining of pain, and the doctor says, well, it's time for you to go home. Like, your symptoms aren't severe enough for you to need more medication or further evaluation. So she was recording herself, and I chose not to put the recording here. I'm respecting the body and not trying to activate folks or re-traumatize you, but if you're interested, you can hear her stories where she was recording herself and her experience in the hospital while she was sick. And she said, this is how Black people get killed. She had this neck pain that wasn't addressed. And she said, the doctor made me feel like a drug addict, and he knew I was a doctor. So at the time, she was trying to advocate for herself. And this is someone who's knowledgeable, wanting to be transferred to another hospital. And ultimately, she didn't survive. So this happened 2020, Dr. Susan Moore, around even educated folks are experiencing difficulty. So why are we talking about this dilemma around medical research and studies? So there's so many different barriers and access points. And the one that we want to focus on tonight is medical research, the benefits of BIPOC folk participating in medical research. And one of the first talks that I had with Jamie, I asked her, why are you so interested? And she said, it's not good medicine if it's not inclusive. I added the compassionate part because sometimes that gets lost. But good medicine, good care is inclusive. And that was important for me to hear as a researcher who's mindful of the need to have more participants to be able to better study what symptoms may look like, how it may vary, and ultimately providing better treatment options. So at this time, it is my pleasure to talk to Ms. Jamie Seltzer, the Director of Scientific and Medical Research at ME Action. She is a patient advocate, but also a researcher. And I think it's really important that we hear from her around the study that she's doing and the value that she's placing on in getting more BIPOC representatives to participate. Thank you.
Thank you so much. I really appreciate the lead-in. Hi, everybody. My name is Jamie Seltzer, and I'm the Director of Scientific and Medical Outreach at ME Action. I also have a lot of the diagnoses that I investigate, including ME/CFS, POTS, and hypermobility disorders. My mother and sister were also diagnosed with ME/CFS. I started working for ME Action after I got sick in 2016, and I was writing articles about science at first. And then I started going to scientific conferences to represent ME Action, and that's where I met people at Stanford and was eventually hired to work there. And now I work with people with ME/CFS and other chronic complex diseases at ME Action, research institutions, and government institutions. So what is ME/CFS? Myalgic encephalomyelitis, chronic fatigue syndrome. It's a chronic complex disease, which means it has many symptoms in many different body systems, and that has to be managed day to day, every day. There are important symptoms in the neurological system, so the brain and the nerves, in the immune system, and in cellular metabolism. There are some problems like slowed metabolism. Even though it's triggered by an infection like COVID or mono, for example, it does still run in families. So there are probably some natural differences in the immune systems of families who go on to develop these diseases. It's also really common. Millions of adults have ME/CFS in the United States. It's really common, but few have heard of it. So what does it look like? Post-exertional malaise is considered the cardinal symptom of ME/CFS. It's when your symptoms worsen or new symptoms appear after you've overdone it. This could be physical overexertion, like maybe you went for a walk. It could be cognitive exertion, like maybe you read a difficult news article. It could even be something with emotional impact. And sometimes there's a delay of about 24 hours between the triggering event and your symptoms getting a lot worse. People with ME/CFS also have exhaustion that is not typical based off of the activity that they've been doing. It's not just because they worked too hard. It's not lifelong, so there's a definite moment that that exhaustion starts. And resting doesn't fix it. People with ME/CFS often go to sleep just as exhausted and wake up just as exhausted as when they went to bed.
Yeah. So I imagine like if you have an active lifestyle or maybe kids you're looking after or just interests that you have, that it could be really hard living with this and not knowing
Yes,
what's maybe going on.
absolutely. So I have a very good friend who was diagnosed in early 2020, right before COVID hit the United States. And she has 2 small children, and it really is almost impossible for her to keep up. Obviously, if you have this reaction when you've overdone it, kids are very wonderful and also very demanding, and they need your time and your energy and your love. And so she does experience worsened symptoms from that. And I've heard ME/CFS called the perfect thief or a custom-made prison, because wherever you would normally want to pour your energy, whether that's into family, or maybe you dance, or maybe you do art, or maybe you're really involved in your career. That thing where you normally put your energy is the place that hurts you the most. Because pushing beyond your limits is what makes you sicker.
Yeah, and even just like going to work, and the story that comes up is on our blog. One of the staff that I had at the time, she was recently diagnosed with ME, and she was feeling happy, but I remember leading up to that, she was feeling really bad that she had to call off or needed time away and super apologetic. And I was like, girl, do what you need to do to take care of your health. That's number one. But coming to finding out that it was something, an autoimmune concern, she felt reassured that she can get support. So like on our blog, she wrote about her experience and about the condition that I otherwise wouldn't have known about. I would have said, like, I know a lot of exhausted people, but she was saying it felt different. So the way that it can present can cause issues, it sounds like, in your day-to-day life with very normal daily activities.
Absolutely. And only about 13% of people with ME/CFS are well enough to work full time. So we're going to talk about severity on our next slide. And we'll discuss kind of what that looks like when it gets pretty bad. But you do have more minor presentation, and the more you moderate your activity and make sure you do your activity in small sections, the more likely you are to stay as healthy as possible with this disease. So let's talk about the remaining symptoms. So people have unrefreshing sleep, and they might even have inverted sleep rhythms. So they feel very alert in the evening and completely exhausted during the day. And then cognitive impairment and orthostatic intolerance. So people with ME/CFS might have orthostatic intolerance and other signs of autonomic dysfunction. What that looks like for the person could be dizziness or an uncomfortable thumping or increase in their heart rate when they change position, like stand up from sitting down. And they do sometimes actually pass out. Cognitive dysfunction, many people call brain fog, but it's a bunch of symptoms in a bucket. Memory issues, symptoms with problems with focus or attention, even trouble reading and recognizing words can be part of this. So this is the median quality of life of ME/CFS. It's a life-altering diagnosis for most people. On average, people with ME/CFS have the lowest quality of life to any disease to which I am aware it has ever been compared. This is the EQ5B3L score. Basically, this is a survey, and people take it in and answer questions about their lives and their symptoms and what they're capable of accomplishing. And then those get made into these scores. So the one for ME/CFS, the bars for ME/CFS are all the way on the top left. And as you can see, the median, so the value in the middle, quality of life in ME/CFS is much higher than the mean or the average. And what that really means is that our sickest people with ME/CFS are very, very sick. The worst case scenario in this disease could be bedbound with trouble communicating and severe sensory reactivity. And the lack of good research and FDA-approved medications for the disease may in part explain the difference between the quality of life in people with ME/CFS and people who have other neurological diseases.
Meaning that when people get access to appropriate level of care, it can improve your quality of life, even with a condition like ME/CFS. So you see, like here, that sticks out to me, folks who are living with schizophrenia and depression can have a quality of life if it's managed well. So I think that's the thing that kind of sticks out to me, is to see the the difficulty and the quality of life aspect. And these are things like showing up for fun events, being able to excel in your career, or just like sit up and enjoy a movie, right?
Absolutely. And yeah, a decent treatment makes all the difference in any disease. I think that it can be really dramatic too, in a way who have been, in people who have been sick a long time. It's even hard to picture, but you find the right intervention and it can make a difference for people. Sometimes it's a process too. You know, you have to try different things, and perhaps one medication gives you 5% more. So that's part of what makes ME/CFS a chronic complex disease, is that it is a manner of managing it every day over time. So I want to emphasize that ME/CFS is not a new disease, even if it might be the first time we're hearing about it for some people on the call. It's worldwide and multicultural. It affects all ages, all genders, but women at a rate of 3 to 1. Community-based studies do show that BIPOC folks are just as likely to get ME/CFS, if not slightly more so. However, mostly white women end up receiving a diagnosis. This is really concerning because ME is so often a post-infectious disease, and we're obviously in the age of COVID-19. COVID-19 has had a disproportionate impact on BIPOC populations, which means we're going to expect to see a lot of post-viral disease in BIPOC people. So we are seeing this now. Many people are experiencing long-term symptoms after COVID-19, like problems with their memory and focus, unusual post-exertional responses, shifts in their hormones, fatigability, and muscle weakness. Symptoms that are not necessarily the same ones as the original viral infection. In fact, they have all of that on top of sometimes symptoms caused by viral damage. Many people with long COVID are now being diagnosed with ME/CFS. It has been estimated that ME/CFS cases are expected to double or triple due to COVID-19. And so if you notice that your friends and family have had COVID and time has passed and they continue to have symptoms, it's something to keep your eye out for, the diagnosis of long COVID. So I'm going to say I am mindful of re-traumatizing people. If you would like to do so, you can feel free to mute me until I move on to the next slide. So I'm going to mention some upsetting things right now. So there are some medical myths that still persist about BIPOC people. The study that was mentioned earlier, clinicians believing Black skin is thicker or that Black people are less sensitive to pain, that's a 2016 study. That's relatively recent. And both Black and Hispanic individuals are less likely to receive pain medications overall. So there is a concept of white feminine fragility and Black toughness that lingers in healthcare and adversely affects both groups. Media sources that dismiss long COVID will often use images of fragile white ladies with their fingertips delicately pressed to their foreheads, exploiting the myth of white women's fragility and barring BIPOC women from receiving the right diagnosis. BIPOC women are more likely to receive a diagnosis of fibromyalgia if the person has that diagnosis and they notice that they also have post-exertional malaise or those unusual symptoms after activity. ME/CFS might be a diagnosis worth looking into. And this is my friend Wilhelmina, who's actually here today. And she agreed to be quoted regarding her experience as a Black woman with ME/CFS. Just in case it's a little hard for you guys to read, I will read that aloud. Lamina says, even though there were no effective treatments, I knew that I was not alone, that there were many others whose stories were strikingly similar to mine. What I was not prepared to learn was that as an African-American woman, I was considered to be an anomaly, an oddity, a rarity. Black people were not supposed to have this disease. I pored over article after article about this disease. Everyone had a picture of a white woman in distress. accompanying a story of a person with my disease and my story, but not my ethnicity. Still worse, I began to read absurd explanations from those in authority, supposedly explaining why Black people did not have this disease, that we had been exposed to more pathogens at an early age, for example. Meanwhile, I was hearing stories from all over the United States about other Black people whose lives were crushed by this disease, just as mine had been. Those responsible for the health of the people of the United States did not acknowledge them. I want to give us a moment to absorb that.
If anyone has any thoughts about this, I mean, Miss Wilhelmina is here, so if you have anything you would like to add, but this is how care is right now, specifically for this condition. So thank you for allowing your words to be shared. And if anyone has anything to say about this or like shocked, because I was when I learned about it, now would be a good time.
I think we do have a lot of people who are on the call who are old hands at this. So I'm hoping that we can all have a conversation together at the end, but I think I will scoot forward. Okay, so why is it so important that researchers talk about inclusion? My feelings around this developed when I first gave a talk at Stanford on why it was important to include BIPOC individuals in research. I was working with a group, and me and my friend group at Stanford had noticed that most of the people coming in were white people. And we knew that this disease affects everybody. And we also knew that people were coming from far and wide to participate, so it was not a community issue. And then somewhat based off of that, when I launched the Postcards to Doctors initiative in like later on that year, which was an initiative like Postcards to Voters, we used handwritten postcards urging doctors to take medical education courses in ME/CFS, and we asked patients and volunteers if they were willing to write them. Then we wrote a program that ensured postcards would be sent to good doctors, not just in the sender's neighborhood, but in diverse neighborhoods all across their state. Because I recognized that since most of the people diagnosed are white, if we did not do that, we would only end up educating doctors who served white communities. So then I started recruiting for the Chronic Illness Survey Adventure just a few months ago. And I couldn't believe it. Within just a couple of weeks, we had met our goal for signups, which is astounding because I was told by multiple people that would never happen. And then I filtered for the number of Black responders, 8 out of 2,000. And this is the thing that really kills me. I told this to other researchers and asked them for advice, and they were pleased that I had found 8 people. So what does this mean? Apart from being surprising, what does it mean? It's terrible for research. If you want to make sure that your data is meaningful, you have to study a representative group of people who have the disease, and we aren't doing that. So it's poor research and it's unethical to not at least do your very best to ensure that this is not the way. At the same time, the second part, the congratulations, there's no expectation of inclusion. So I'm not encouraged nor expected to work on inclusion by other researchers, despite the fact that that should absolutely be the standard. I'll pause there, see if anybody has anything to say about that. Y'all are awfully quiet, but it's okay if it's all percolating.
I think as just a lay person, when I'm looking at research, I have not always looked for who the study sample included. And I think sometimes when we do research, okay, the numbers look good, but that's an important point to consider when we're looking at research. Were people like me, either from my zip code or my ethnic background, included in this study? So that's what stuck out to me is I don't necessarily look for that in study samples when I'm looking for good research on things that could be helpful for me.
Well, and I think that it might be different. Well, I know it's different in some other diseases where the diagnosis is more equitable. I think that part of the issue is that ME/CFS is diagnosed by symptoms. So you can't just go in and get your blood drawn and get a yes, no. Your doctor has to go through this long, elaborate process. And every step of that process bars more and more and more people from reaching the diagnosis that will give them the right advice and access to the right meds and a name to call what's happening to them, which I think is underestimated in terms of its power. You name the thing and you have power over it. I really think that that changes lives to be able to know what's wrong. So I think if you look at a study for cancer, there's a decent chance that it will be diverse. But you look at diagnoses where there are more barriers in the way and probably not so much.
Okay, thank you.
Okay, so why is there low participation? I did just mention one of the reasons, but let's look at it from both the participants' point of view and the researchers' point of view, rather than necessarily like systemic issues that affect this diagnosis in particular. Researchers aren't always prepared to answer concerns of BIPOC individuals about participating in a study. Common concerns include the history that we were talking about earlier, and also privacy and what the data will be used for. And a lot of people don't know that you should come with something in your hand. If you have a community that you want to engage with, it's wonderful to have something to offer. And I do have a few offerings today at the end of our presentation. People might have found interactions with health and medicine challenging in the past. They might have a particular memory that rises up in their mind and or their body about the last time they interacted with science or medicine, and that's not always going to be a pleasant one. Sometimes they're just not sure. Yeah, I could do some low effort involvement, but I'm not sure where to go or where to look. And then we get to the barriers to do with the diagnosis itself. And finally, in diseases that affect more women than men, which we haven't really discussed yet, medical misogyny is an additional barrier. So for example, women are interrupted by their doctors significantly more often than men are. By female doctors too, by the way. So there are a lot of benefits to actually ensuring that everyone takes part. The first one is, of course, ethical. Nothing about me without me. You can't say something about a population when they haven't participated, they're not in the room, they're not part of the team. Some medicines work differently in different populations. So for example, ACE inhibitors. And also the patient voice matters because patients know their disease. Patients describe their symptoms in more detail, and they describe more symptoms than their doctor does, even describing the same exact condition. And research shows this case. Moreover, it may be that different communities describe the same symptoms differently. So that's very important that we include everybody in order to ensure everybody can get diagnosed.
Right. And that's where like the cultural considerations of how we even talk about an issue, whether it's a physical symptom, it may present or be discussed differently amongst different groups. And so what I'm hearing is like having BIPOC, Black, Indigenous people of color represented in research really enriches the data collected, but that ultimately increases better treatment, better care.
It's better quality research, and it's better quality for a reason. It leads to better outcomes, and those outcomes lead to swifter diagnosis, better treatment. Really, honestly, the involvement of everybody from the get-go is the way to do the best job, always. Okay, So now we're zeroing in on our last 10 minutes. So I'm going to scoot through this relatively quickly. The chronic illness survey adventure is what I'm hoping to recruit for, and I would like to talk to you about it quickly today. It's for people with a diagnosis of POTS, hypermobility, ME/CFS, long COVID, or MCAS, that's mast cell activation. The goal of the survey is to use patient-described symptoms that we talked to individuals with each of these diagnoses and asked them to describe their experiences. We also include people with severe presentation of the disease, so to be able to capture the whole spectrum, as well as symptoms from validated instruments that are already produced to talk about complicated symptoms with many dimensions like fatigue. We hope that this can show us mechanisms of disease, show us how symptoms cluster together. Like if someone has symptom X, are they more likely to also have symptom Y? And figuring out how those connect together could maybe help us understand what the best treatment would be. And it might also show us which diagnoses people are more likely to receive and let us make inferences about why certain people have access to that diagnosis and others don't. So the survey is safe, it's accessible, it's easy to read. Sections take just 15 minutes at a time. The study was judged IRB exempt, that's Institutional Review Board. They assess the safety of studies, and the fact that it was exempted means that the study is considered low risk to participants. The data is only about your symptoms and the diagnoses that you have. And the data can only be shared with researchers working on the study. And the ultimate goal is to make sure everybody gets the right diagnosis and the right treatment as fast as possible and accurately as possible. This can help people in your community. All these diseases have a hereditary element. So if you have one of these diseases, you could be helping those who are closest to you. We need healthy controls too. So if you're a healthy person on the call, your mind, body health is good, we would love for you to participate as well. Okay, so this is what it looks like. I'm going to go ahead and drop into the chat, if I can access it from where I am actually. Having a bit of trouble getting the buttons to pop up. Sorry, guys. I'll do that at the end.
Yeah, you could drop it in when we switch back to me.
Okay, thank you. So this is what our landing page looks like. You have our little description of the study, and on the right-hand side, you just click on the button to sign up. Very simple. You go to this page, you pick a username out of the top of your head, put your email in and click the arrow, and then check your email and you'll have your own personalized link to take survey 1. There are 6 sections total. You'll automatically get each subsequent section emailed to you, but you can just opt out if you decide you don't want to participate anymore, and that is okay. There is an extensive FAQ. One of the things that we talked about was making sure that everyone understands about a study so they know where the data is, what it's being used for, who's doing it and why. And this is where you can find all the answers to those questions. ME Action has actually done quite a lot about inclusion, but I want to make sure that we have enough time to do questions. So let me sort of scoot through these relatively quickly, and then I'll pass it off and just make sure that we don't have anything. Okay, I'll also be dropping these tools. These are the offerings that I have in order to come with something in my hand, like a potluck. And there we go.
Thank you.
Okay.
Thank you. Let me move through.
I'm going to go ahead and stop sharing, and I'll drop some of those links into the chat.
Okay. You can see my screen now, right?
Yes.
Okay, cool. So I want to thank Jamie for sharing not only the benefits of having BIPOC included in research, but taking the time to let us know what her study looks at. what we can expect from it. And I feel like that part is missing sometimes around what are you going to do with this information and how is it going to be helpful? That I believe that folks are more inclined to participate when you give me some details. And we had a discussion even prior to the talk today around, well, how are you going to ensure the safety? How are you going to make sure that folks are respected or feel respected during this process? And she took the time to explain to me, and I said, well, I think the community needs to know what's going to be involved. So if you have questions about this study, it's still open. How long will the study be open until?
The study is going to be open until well into next year.
Okay.
We've released the first 2 sections, and we're going to keep releasing sections at different intervals. I estimate we'll have all sections out by February of next year.
Okay, thank you. So my particular interest with Urban Health Group is to make sure that folks are informed and empowered. And this is one way that we can get empowered in our care is participating. But I do want you to consider participating. I understand that there's apprehensions. I understand that there's huge concerns. So when we talk about the dilemma around, even as we were beginning to put the presentation together, like what can we offer? What can we share with people? I cringed a little bit thinking about how folks have been abused by some of these systems that were meant to provide quality care. So I put this picture here because I want us to show the diversity in what BIPOC folks could look like. What we're doing is wanting to make sure that the picture never gets missed, and that's the people. So whether it's medical research or interfering with your doctor, that our humanness, our humanity, our flesh and bones, let us not forget that part and remember that we all deserve quality care, and looking at the faces and getting familiar, even if they look different than yourself. So I really appreciate Jamie and Emmy Action talking about their approach of using research as one tool to address those barriers to care. Now, the other thing that we wanted to talk about in this era of COVID-19 and folks really being empowered to do their own research, there's a lot of wild stuff, a lot of misinformation and changing information. We want to provide some tips of how you can do your own research. That is a very good thing to do always. But with the internet, you click on a headline that sticks out to you and you run with it. When it comes to informed care, there's some really straightforward things you can consider. So for folks who are actually reading medical journals or articles, to look at the funding, who funded this research? When we looked at the wellness industry, when we looked at nutrition, when the dairy farmers are funding the research, they may have a certain interest in making sure the data is skewed to look favorable. So when you're looking at medical research, look at the funding to assess if there's some biases, if they have a particular interest in making a number stick out.
If it turns out that the Department of Work and Pensions is studying a chronic disease, perhaps that is not the best source for funding.
Just, perk those ears up, dig a little deeper, because the numbers can look good. So one tip is look who's funding. The sample size, how many people are actually in the study? The amount of people can make a difference of looking at the probability of that issue being more prevalent than it is. So with Jamie's study with Emmy Action, looking at the chronic illness survey adventure, 2,000 people is a huge amount to get some good data, but we looked at who are those people, right? So being able to look at, is it just males participating who are 50 years old and between 50 and 60? How applicable might that be for me? Being skeptical of opinion articles and catchphrases. Now, medical providers and medical institutions and organizations do write articles that are opinion pieces. So being more mindful that this is this individual's take on the situation. Maybe you have a relationship with them and you really value and respect them. I get that, but be mindful that even folks with credentials are saying some really dangerous things and concerning things. When it comes to issues like that, well, doctor said it, right? Consulting the experts versus the influencer. So if you're going to pick a couple of reliable sources, I might encourage you to go with the expert of that specific thing that you're looking at versus your favorite wellness influencer. Jamie, any input on who the experts are?
The patients are the expert. That's a little glib, but as long as the information is filtered through science, I do think that people with experience are the people who are best able to describe the situation. In terms of experts, I would say if you're going to seek health advice, you want somebody with a degree in healthcare. And if you're going to talk about climate science, you want a climatologist, period. Yeah. I think one of the biggest, most common errors that I see in this kind of area is that people assume someone who's an expert in one arena, like they have a PhD in immunology, they understand immunology very well. It doesn't really mean anything about any other aspect of anything at all.
Yeah. Ultimately, trust your gut. When it comes to care, it's your body, it's your care, it's your choice. So I can't tell you to do or not do anything to really build those internal trust within yourself that I believe you're going to make the best choice for yourself. And here are ways that you can even be more informed on how to make those choices. So I will provide this information on what to look for. So .gov.edu around when you're looking online, how to identify these sources. So huge thanks to Emmy Action and Jamie for taking your time to put this together, but also share with us the study that you're currently conducting. This is her information of how you can get in contact with the organization and you directly, right?
Yes, on the right is my email address and also my Twitter handle. So if you'd like to reach out to me there, you're welcome to do so. And I see Susan is saying good night. Thank you, Susan.
Yes. So any thoughts, feedback, questions on today, what we talked about? Anything that stuck out to folks?
Feel free to turn your camera on if you would like to.
And I believe you can unmute yourself as well. Uh-oh, go ahead.
I see Wilhelmina has her hand raised up.
I do. And thank you all. This was a wonderful presentation. Thank you both. One thing I wanted to mention to people, if they have not seen the movie Unrest, that's a great source. Emmy Action was founded by two women, one of whom is a person of color. She's a biracial woman. And the movie Unrest is Jen Brea's story. Jen also has a TED Talk that explains her experiences with this illness. And people, it's been a great way to reach out to a community that's been neglected, because when they see Jen, I frequently say this, they see somebody who could be their cousin who's going through exactly the same thing, and that means a lot. Yep. So I would like to suggest, if anybody has not seen the TED Talk and the movie Unrest, those are great things to do.
Thank you.
And I will add that it is an amazing documentary in its own right. It won at Sundance for best editing, I believe. So it's also just like an honestly incredible film.
Agreed.
Thank you. Well, we will also make the resources and information available after this, after today. So you would be able to refer folks to watch this on YouTube. I believe Emmy Action will have some ways that you can connect to their resources, Urban Health Group. If you have questions on navigating your healthcare needs or how to connect to more resources, we will be very happy to point you in the direction of Emmy Action. But we want to encourage folks to participate in this study. We want folks to consider the benefits to yourself and your community of how we can be the change in providing better data for better treatment, better care, better wellness for BIPOC. So thank you all tonight.
Thank you, everyone. I really appreciate you coming. It's wonderful to see so many familiar faces. Thank you, Carmen.
So if there aren't any more questions, feel free to reach out to us individually, but thank you all for sitting in with us tonight. Thanks, Jamie.
Thank you. Are you going to stick around a little bit or do you want to
Yeah, one sec.
jump off?